Welcome to Dr. Twyman's weekly Ask Me Anything. Tonight we have some great questions about can plaque be reversed, who's appropriate candidates for statins, beta blocker use for anxiety. So thank you for all those that are joining tonight, and thank you for those that already submitted their questions. So if you'd like to put in a question tonight that you want me to answer, just drop it in the comments below and we'll get to them as we go. But we'll start with question number one. Question one tonight. Person's father is 82 years old, has aortic valve calcifications that is progressing rapidly. Anything to reverse or slow? So depends a little bit if the valve is bicuspid or tricuspid. If you have a bicuspid aortic valve, they tend to degrade more rapidly. 1% of the population has a bicuspid aortic valve. But if that's not the case, then you have to know what the person's vitamin D levels are. Ideally, vitamin D levels would be between 50 and 60 without supplementation, because you need optimal vitamin D levels and optimal vitamin K2 levels to keep calciums in the bones and prevent it from building up in the arteries and on the valves. So start there. And then lipoproteins, especially if you have high levels of lipoprotein A, more likely to develop aortic valve calcifications. So you may have to treat ApoB with other modalities if you have high Lp(a). Next question up tonight. Person is a 64-year-old woman and consumes 1 gram per kilogram body weight of vegan protein. Are they at risk for sarcopenia? They walk and do yoga. Great question. Thank you for answering it. It sounds like you're already at least having the right questions in your mind. Is that, healthy aging is all about the health of your muscles. My friend Dr. Lyon, her book Forever Strong is coming out tomorrow. So if you haven't bought a copy yet, still time. You can go on Amazon and get one. I bought a few copies to give out to family and friends. The section on the lipoproteins, I had a little bit of a help in helping draft that portion of her book. But that book will give you kind of the science-based approach to why you got to think about your muscles as the organs of longevity. You can get your protein intake, through vegan sources, but you have to plan for it like you are. Generally you need about 30 grams of protein for any one meal to activate muscle protein synthesis. You're looking for the amino acid leucine to be around 2 to 3 grams in that setting. And then walking, while it's great activity, is not usually exercise because you're not really putting a metabolic demand on the body. And yoga, there's definitely some strength components to it, but you really want to focus on doing resistance training against weight. So it can be body weight exercises, but kettlebells, resistance bands, machines, particularly if you don't know what you're doing, find a trainer and help get a program designed for you. But you definitely want to do your best to continue to avoid sarcopenia, because if you lose muscle mass, your metabolism goes down and you're more at risk of fractures and falls. So do everything you can to limit the amount of muscle mass that you lose as you age. Next question of tonight. What are my thoughts on beta blockers to help anxiety, specifically metoprolol? So beta blockers can be used to help some people who have kind of stage fright, is usually the main reason why they would use it, or people who are giving speeches. Beta blockers knock down adrenaline. Adrenaline's your fight or flight hormone. So, the tiger's chasing you, you got to dump adrenaline, run from the threat. But, public speaking often is something that is more fright-inducing to people than many other things in their life. Beta blockers might help some of those individuals. Classically, it's generally going to be more the propranolol that helps with that because it's less cardioselective. Metoprolol is a little bit more cardioselective, but B1 receptor agonist. So metoprolol may not work as well for anxiety compared to the non-selective agents, and usually propranolol is utilized for that. Next question of tonight. What is the relationship between fatty liver, which is steatohepatitis, steatohepatosis, and cardiovascular disease? Great question. So you would first start by looking at a traditional lipid panel. And if you have high triglycerides over 500, you're definitely more concerned. But even if you have triglycerides over 150, still may be concerned that you may be at higher risk for fatty liver disease. And fatty liver can be caused by many things, but the most common would be alcohol, and then non-alcoholic steatohepatitis, which is overcoming alcoholic steatohepatitis. So that is generally driven by high fructose loads. So sugar sweetened beverages are the biggest actor for that, sodas, but also just highly processed food diets, with high carbohydrates more than your muscles can handle, will be contributed to making more triglycerides that your muscles aren't using for energy because you're not moving them well, and you're already kind of shoved all the triglycerides into your fat cells that they can hold, so you spill them out into the bloodstream. But then some of those triglycerides are basically going to be deposited on the outside of your organs, and that is visceral fat. That visceral fat is very inflammatory as it drops its different hormones and compounds directly onto the liver itself. So that will drive oxidative stress and inflammation, and your 60,000 miles of blood vessels are going to transport those compounds through them, and in the process likely to damage the glycocalyx and underlying endothelium. So fatty liver is a marker of poor metabolic health, and poor metabolic health is a risk factor for cardiovascular disease. Next question is a great one, and I talk about it with all my patients at Apollo Cardiology, is how big of a risk factor is family history and your risk of heart attack? So I tell people, your family history is important, but it's not the only thing. And I will, assess people based off their story. But I talked to somebody today in the office, and I told them, yes, I know your dad had an event, but I want to know about your mom first. The reason I want to know about the mom side of the family first is because you inherit your mitochondria from your mom, and she got it from her mom. And your mitochondria are the organelles in your cells that they do many things, but they're going to make energy for those organs. And your heart and your brain are the two most energy-dense organs, sans the ovaries. So if your mitochondria from your mom were weak, she had heart disease, neurodegeneration, cancers, autoimmune conditions, then more likely you have weak batteries that are prone to those same conditions. But if that's not the case, then yes, I do want to know if you've had family members have heart attacks and strokes, especially if it's under the age of 55. If that's true, then the 3 or 4 major genes that I will assess in patients is always going to be lipoprotein(a) or Lp(a). Up to 20% of the population has high levels of Lp(a). It's the number one genetically inherited lipoprotein that increases the risk of early cardiovascular disease, and is under genetic control. The other one is an ApoE4 allele. You get a copy from your mom, a copy from your dad. The 3 is the normal allele, 2 is somewhat cardioprotective. The ApoE4s tend to have more cardiovascular disease. And then 9p21, sometimes colloquially known as the heart attack gene. You have high markers of endothelial dysfunction. 9p21 is often present. And then sometimes I will check KIF6 or KIF6, can increase the risk of aortic aneurysms in addition to coronary disease. So check those in people who have strong family histories. But that being said, still probably 70–80% of your risk of cardiovascular disease is through your lifestyle, which is not a great term because everybody has a quote lifestyle, but it's how you move the body, how you fuel the body, how you move your body through space, and then the other ones are going to be how you manage your stress levels, because stress is ubiquitous. Stress isn't necessarily bad, it's just how do you respond to it, and then how well do you sleep, because if you don't sleep well, your mitochondria are not going to repair themselves. So your environment has a bigger influence than you suspect. But family history, if you have a strong family history of early cardiovascular disease, there's often a gene playing a role, and often it's through these inflammatory pathways that affect the endothelium. Next question tonight. Somebody says when they need a medicine for high blood pressure, but they got adrenal burnout, but it's not constant, they're fit and active though. So I don't know all the details in this, but I would kind of get to a point where, if your adrenals are not working, you're probably going to want to avoid the beta blockers, because you want to be able to, have a stress response when needed. The question earlier about beta blockers, it knocks down adrenaline. So maybe you're not wanting to use that if you really have adrenal fatigue. But most people, the first or second line agents are going to be the ACE inhibitors and the angiotensin receptor blockers, and then the calcium channel blockers with medications such as amlodipine. And that's if exercise, potentially a DASH type diet, a dietary approach type of hypertension doesn't get the blood pressure down. And then there are other nutraceuticals and supplements that can be used at times to help lower blood pressure if you need to work on it before going to pharmacological therapies. Next question, can plaque in the arteries be reversed? Person is a 66-year-old woman with plaque and was put on a statin. So the short answer is yes, plaque can be reversed, but it sort of depends on what you mean by plaque. Is the plaque already calcified? Well, unlikely that plaque will be, quote, reversed. It probably is just going to stay stable and not go anywhere. It's the hard plaques that tend to become more stenotic over time, and if you restrict enough blood flow, you may have stable angina, but those aren't the plaques that you're as worried about causing heart attacks. Typically, it's more the softer plaques, the plaques that are less mature. They're generally less than 50% stenosed. You're not necessarily going to feel those type of plaques. So those softer plaques can be reversed if you stop doing damage to the artery. So if you get the ApoB particles down to the 20th percentile, generally an ApoB less than 70, if you keep oxidative stress and inflammation low, which can be monitored on blood testing, and you keep healthy nitric oxide levels and healthy endothelial function, then yes, it's more possible that the plaques will be reversed. And the best way to really assess that is with a carotid intimal medial thickness scan, or if you had CT angiograms, you may be able to see that. If you only had a calcium score or a CT coronary calcium score, you're not going to see the soft plaque. Often those scans will be a little bit confusing because if you're doing a lot of the things that we talk about to help stabilize plaque, those soft plaques become hard plaques and the calcium score test goes up. You're not necessarily getting worse, you're taking the stuff that's likely to cause a heart attack and stabilizing it. But great question, and that's one we answer every single day with our patients at Apollo. Next question up tonight, a 70-year-old woman with a calcium score of 0, which is low risk, but their non-HDL is 189, which would be elevated. Their LDL cholesterol is 177, which would be elevated, and they have very high triglycerides of 257. The question is, are they too old to start a statin? The short answer is no, but the next question is, are you on any treatments other than statins at this point? What dietary interventions have you tried? Are you physically active? Are you getting 150 minutes of moderate physical activity a week? If you are, okay, well then maybe you need to consider pharmaceutical options to modulate the lipoproteins, something like bergamot, berberine, maybe fish oil. But if you're going to be on pharmacological agents, statins are not contraindicated in somebody 70. High-risk calcium score over 400 really should consider statin therapy unless there's a strong reason that there's a contraindication to it. They've had muscle symptoms on previous statins. They have an ApoE4 allele. They have an SLCO1B gene mutation. They're CoQ10 deficient. They're vitamin D deficient. They're hypothyroid. Then you want to be a little bit more careful with statin therapy in those individuals. So hard to say for sure. What is the best treatment without looking at some of the metrics of the soft plaques and endothelial function. But no, statins are not contraindicated for a 70-year-old with a calcium score of 0. But the people who benefit more tend to be people with higher risk scores. But that being said, LDL-C, and non-HDL, those are the surrogates for apolipoprotein B. That's what you'd really want to assess. And if that's elevated and you can't get it down with lifestyle, then you want to consider therapies that will help get you to your goals then. And this question also plays into the lipoprotein questions, is if your LDL particle is high, but your small dense LDL is low, what is your assessment of it? It's still a risk. Particles follow the risk. And it used to be thought more about large fluffy LDLs were non-atherogenic or plaque forming, and the small dense LDLs were like BBs and they were more atherogenic. But that's not necessarily true anymore. It's more about the total number of particles. Particles predict risk. Think of them like cars on the highway. The more cars that you got, the more likely you're to have a traffic jam. The small dense LDLs mostly are going to be elevated for two reasons. One, it's possible the person is insulin resistant. you'll find that also by looking at their triglycerides, their HDL. You'll look at their fasting insulin, generally should be less than 8. You can look at their hemoglobin A1C, generally should be less than 5.1. And then there's HOMA-IR and some other insulin resistance scores that you can look at as well. Those usually track. If you have high small dense LDL, you'll have other markers of insulin resistance. But there are some genetic reasons why some people make small dense LDL, and those small dense LDL have a tendency to potentially more oxidize. If they get oxidized, there's more likely to cause vascular inflammation with that. So still not a clear-free situation where your small dense are low and you have high LDL particles. You want to treat your LDL particles to goal, or if you have ApoB, to goal. And if you have any amount of plaque in your arteries, your general ApoB goal should be less than 70. If you've had heart attacks, strokes, stents, bypass, or you're just a very high-risk individual, you're potentially going to be in the 5th percentile, so an ApoB less than 55. All right. And then the last pre-populated question, somebody's asking about where's my next fun trip. Well, thanks for asking. I have a lot of trips coming up, but most of them are business related. This upcoming weekend, I'll be in Chicago teaching some doctors about the endothelial glycocalyx. Then a couple weeks from then, I'll be teaching at the Silverback Summit, teaching guys about cardiovascular disease and the risk of hormone replacement therapy. I'll be talking a lot about endothelial health, vascular inflammation, the clearly CT angiogram to tell you if you have soft plaque in your coronary arteries. So that trip's coming up. That'll be down in Austin. But those are mostly work-related. The next fun one is I'll be going to Savannah in a few weeks for kind of a fun conference for myself. And Savannah is one of my favorite cities in the world. I used to live in the Low Country when I was in the military. Savannah was about an hour away from where I was stationed in Beaufort, South Carolina. Beautiful southern charm. So really looking forward to that trip. All right. So I think I got through all the pre-populated questions. I thank you guys for your time and attention for those. I'm looking for any questions that we got in the comments here. See one family member on board. So somebody's asking me which blue blocking glasses am I wearing. These are my EMR Tech Wolverines. These are my favorite pair for kind of daytime use. They're just pimping, 24 karat gold plated. They just fit my face well, and just like them a lot. So I have many pairs. I used to tell the joke that I have more blue blockers than I do shoes. I don't think that's necessarily true anymore. Sometimes I switch them out, in the office or when I'm traveling, but for most of my kind of IG lives or podcasts, I tend to wear these because these are kind of my favorite daytime ones. So somebody's saying that they think the volume's low. Yeah, I'm using a very cutting edge Rode microphone. I tested ahead of time. I know I speak a little bit soft. I've been talking to patients for 8 hours today, so sometimes my voice is a little bit raspy by the end of the day. The trick is, if you can't hear on a phone, is plug in a set of headsets to this, or I will download this video. I'll upload it to my YouTube channel. It's just Dr. Twyman, spelled like my name up here on YouTube, and I'll try to play around with the sound there if I can. There's Dr. Line. I see she joined, so welcome. Good luck with your book launch tomorrow. Very proud of you. Happy for you so much. I'll be in touch soon. Somebody's asking, do I suggest going vegan if you get side effects from Zetia or Repatha? Not necessarily. It depends on why you'd want to be vegan. I mean, if that's your choice, that's fine. But from a lipoprotein standpoint, it doesn't mean that your lipoproteins are going to necessarily go back to normal. There is a large genetic predisposition to having higher lipoproteins. You can check an ApoE genotype to see if that's your propensity. And then I also really like looking at the cholesterol balance test in the Boston Heart Lab panel. If you're a hyperproducer of sterols, then that's where statins or bempedoic acid tend to work. If you're a hyperabsorber, that's where ezetimibe tends to be. So if you can't tolerate, ezetimibe or Repatha, then there's other PCSK9 inhibitors, Praluent, Elasclerin. You would consider that. But Typically, just going vegan by itself is probably not going to get you necessarily to your goals. Sometimes if you cut, from a full-on kind of call high-fat keto diet that's very high in saturated fat and cut down on saturated fat to maybe 80% of your total calories, you'll see some significant drop in the ApoB particles, but rarely does it get you back down to an ApoB of 70 if that's your goal. So if you need a little bit more information about that, just chat with my office, because I can recognize the name that I've chatted with you before. All right. So I think I got through your guys' questions tonight. I appreciate all the great questions. I'll answer, I think another one just popped up. I'll answer that just in a moment. But every Monday night, 6 p.m., we'll be doing these live AMAs. If you have questions in the interim, just send them to me in the comments or a DM, and I'll hold on to them and I'll answer them Mondays. I'm going to be trying to play around a little bit with some more long form videos on my YouTube channel. So if you don't follow me there, just go to youtube.com, name's up here, Dr. Twyman, and we'll see you there as well. So I answer this one last question, and going back to some other things I got to get to tonight that are going to be exciting coming up in the near future, and I'll let you guys know about those next week. So somebody's asking, is it bad to get 2 different blood pressure readings on each arm? So if it's on the same arm, not necessarily the concern. Generally going to be more concerning if you have differential blood pressures on each arm, especially if there's a 20-point differential. So if you have 20 points higher on one arm, there could be an issue where you have subclavian stenosis, a blockage in the artery in the area under your collarbone going to your arm. I've seen a couple cases of those in my career. And there's some reasons to that where you have issues where the nerves from the spinal column innervating the arteries, the sympathetic tone can be very high on one side, constricting the arteries and raising the blood pressure on that side. But if the blood pressure is high on the same arm, well, that's not that uncommon. The standard recommended ways to actually check blood pressure would be to, take a measurement, wait up to 5 minutes, repeat a measurement, wait up to 5 minutes, repeat a measurement, and average them out. So if there's a slight differential, 5-10 points, not concerned. It's when there's really more than 20 points that you gotta be a little more concerned. So, all right, guys. Well, thank you again for your time and attention, and we'll see you again next Monday night.